Estimation of RVSP with echocardiogram. What is RVSP and how do we measure it? RVSP is the right ventricular systolic pressure and it's measured in millimetres of mercury. Pulmonary artery systolic pressure, or PASP, is equal to the RVSP except in cases of pulmonary stenosis or right ventricular outflow tract obstruction. The RVSP is representative of the pressure in the main pulmonary artery which supplies blood to the lungs. Elevated RVSP can indicate pulmonary hypertension. The RVSP can be estimated on echocardiogram, 1 by the tricuspid valve regurgitant jet velocity, and 2 by the size and collapsibility of the inferior vena cava. Here are the views where TR may be measured from, if there is a sufficient jet. TR jet lineup. TR velocity is measured by continuous wave Doppler placing the cursor in parallel alignment with the jet. Parallel alignment is crucial to obtain the highest velocity or the RVSP may be underestimated. It is also important to use multiple acoustic windows in order to ascertain the highest possible jet. The peak TR velocity represents the pressure difference between the right ventricle and the right atrium in systole. This is a poor TR jet lineup. Note how the cursor is not quite parallel with the TR jet. This is a good TR jet lineup. With slight modification of the AP4 view to the RV modified AP4 chamber view, a much better TR jet lineup is achieved. The beard versus the chin. This is an incorrect beard measurement. This measurement has been taken where the Doppler signal fades away and it's far less dense. This is what we call the beard. The arrow shows where the TR jet measurement should be. Measurement of the chin. Note the clearly defined parabolic TR jet. This has been recorded from the apical long modified view at a sweep speed of 100 millimeters per second, as recommended by ASE. The TR jet with maximal velocity here is 2.47 meters per second. Enhancement of the TR jet is possible with agitated sailing if a full parabolic signal cannot be seen. The TR jets are to be averaged in atrial fibrillation. RA pressure estimation. The American Society of Echocardiography recommends that RA pressure be derived from IVC diameter and collapsibility. When the RA pressure increases, the IVC displays an increase in its diameter and a reduction of its collapsibility. The IVC can be viewed in its long axis in the subcostal view. The patient may be positioned supine or left lateral decubitus, depending on what your lab prefers. A note of the patient's position at time of measurement may be included on the report. Assessing collapsibility of the IVC can be achieved by asking the patient to sniff quickly and also during normal respiration. The IVC should be measured at end expiration perpendicular to its long axis. The hepatic veins are located around 0.5 to 3 centimeters from the ostium of the right atrium, and it's just proximal to the hepatic veins that this measurement should take place. It should be performed with calipers placed inner edge to inner edge. When assessing IVC collapsibility with a sniff via 2D measurement, it is preferable to use a minimum of 3 beats. With IVC M mode, the cursor is placed in the same position as where the 2D measurement is taken, and then M mode is performed. A sweep speed of 100 millimeters per second is appropriate. This table states the specific values given for right atrial pressure after assessment of the IVC. If IVC size and collapsibility does not fit into the first or last category, an intermediate value of 8 millimeters of mercury may be used. However, it is preferable to use other indications of higher RA pressure, such as a restrictive right-sided diastolic filling pattern and diastolic flow predominance in the hepatic veins. If these signs are not present, RAP can then be downgraded to 3 millimeters of mercury. If these signs are present, RAP may be upgraded to 15 millimeters of mercury. So what do we do now? We now know how to measure TR and we now know how to measure RAP. So we should put it all together so that we can estimate the RVSP. Hence, The Bernoulli equation. Essentially, the Bernoulli equation demonstrates the pressure difference between two areas, for example, the right ventricle and the right atrium. In echocardiography, we use the simplified Bernoulli equation as certain assumptions can be made. Flow acceleration can be ignored as there is no acceleration at peak velocities. In the centre of a vessel, viscous friction is negligible. Density of normal blood can be ignored as blood is the fluid and its density is 4. And conservation of energy can be ignored as there is no energy transfer. Here is the simplified Bernoulli equation. The change in pressure is equal to 4v squared. V1 and V2 can also be ignored as the velocity proximal to a fixed opening or orifice is generally lower than the peak velocity through that opening. The Bernoulli equation, conservation of energy, shows the relationship between velocity and pressure. As fluid speeds up, pressure goes down. The velocity through a narrowing must increase in order to keep moving. When this happens, the pressure at the narrowing must drop. Pressure and velocity are inversely related. The maximum TR velocity obtained is then converted to pressure via the Bernoulli equation. In this example, the maximum TR velocity is 2.47 metres per second, and if we assume that the RAP is 3 millimetres of mercury, we can now come to the conclusion that the estimated RVSP is 27 millimetres of mercury. Important. TR velocity demonstrates the pressure difference between the RV and the RA during systole, not how severe the TR is. For example, you can have trivial TR with a peak velocity of 3.5 metres per second, but the TR itself is only trivial. So once we have our RVSP, we can determine pulmonary hypertension values. The different grades are shown in this table. Some caveats with RVSP estimation are free TR cannot be accurately calculated as the RAP is unknown. The TR velocity in free TR is usually very low as the RV and RA are essentially acting as one chamber. The RA pressure evaluated on young athletes may not be accurately represented as the IVC may be dilated and it's a normal variant in this population. In patients who are ventilated, the IVC cannot adequately estimate the RA pressure. Central line can be used to estimate the RA pressure if available, patients such as ICU patients. Some take-home points. Parallel alignment of TR jet for the highest velocity, very important. Measure the chin, not the beard. Off-axis images are okay to get the best TR lineup. RVSP is equal to PASP except in cases of RVOT obstruction or pulmonary stenosis, and beware of free TR. TR velocity demonstrates the pressure difference between the RV and RA during systole and not how severe the TR is.